Chloe Hughes to come forward to speak to us on the longitudinal profiling of a peripheral blood transcriptome and vascular biomarkers to identify patients at risk of major cardiac events following COVID-19.
So I'm presenting results from a study looking at the peripheral blood transcriptome and vascular biomarkers to identify patients at risk of cardiovascular events after hospitalization for COVID-19. And there are now over 600 million confirmed cases of severe acute respiratory syndrome, coronavirus 2 or SARS-CoV-2. And although most people will experience asymptomatic infection or are outpatients with mild illness, in those with more severe disease, the biggest concern was the development of pneumonia or acute respiratory distress syndrome. However, it's becoming increasingly clear that COVID-19 is also a vascular disease. And this isn't just concern in acute infection, but also in post-COVID-19. And this is highlighted by this study, which is previously mentioned, but they showed that there's an increased risk and 12-month burden of cardiovascular complications beyond the first 30 days after infection, and it includes over 150,000 COVID-19 positive participants. And they also found that there was an increased risk in major cardiovascular events, or MS. We have a basic understanding of the COVID-19 pathology, and it's characterised by a reduction in lymphocytes and an upregulation of neutrophils. And they are the most abundant white blood cell and one of the first immune cells to respond to sites of infection. And an increase in neutrophil to lymphocyte ratio is one of the most common markers for disease severity in COVID-19. We also see endothelial dysfunction in COVID-19 pathology with an upregulation of endothelial activation markers as well as dysregulated coagulation. However, whether these events are related to cardiovascular complications following COVID-19 as well as the mechanisms leading to these events is not well understood. And we hypothesise that neutrophils drive vascular inflammation through a variety of mechanisms, including the production of pro-inflammatory proteins through degranulation, as well as the production of neutrophil extracellular traps, which are released from neutrophils, and they are an antimicrobial response. However, they can produce inflammation and they can also cause host tissue damage. So we hypothesise that neutrophils are driving vascular inflammation, which results in endothelial activation and subsequent dysfunction, and this is associated with cardiovascular complications following COVID-19. Our first objective was to investigate the acute inflammatory response in hospitalised COVID-19 patients by carrying out longitudinal profiling of the peripheral blood transcriptome and vascular biomarkers. Our second objective was to investigate whether any changes in the blood transcriptome or vascular biomarkers can predict subsequent cardiovascular disease. To do this, we carried out an observational longitudinal study of hospitalised COVID-19 patients. Patients were recruited within the first 96 hours of hospital admission, and blood sampling was done up to day 29. We also included two control cohorts consisting of a lower respiratory tract infection or LRTI group, as well as a non-infection hospitalised matched control group, and both of the control groups had baseline sampling. For each participant, we took their serum at each time point and measured various inflammatory markers using ELISA. And in the COVID-19 cohort, we took RNA stabilised whole blood at day 1 and 29 and had this processed for mRNA sequencing. To further understand the role of endothelial cells in COVID-19, we measured serum levels of the endothelial activation markers, E-selectin and vascular cell adhesion molecule 1, or VCAM1. And we found that E-selectin was significantly upregulated from day 15 onwards compared to baseline values. However, we saw the opposite trend in VCAM1, and at day 29, this was significantly reduced compared to baseline values. We also measured the inflammatory marker intercellular adhesion molecule 1, or ICAM1, and we found that from day 8 onwards, this was significantly elevated compared to baseline values. We then measured von Willebrand factor required for hemostasis and found that this was upregulated at day 8 and 15. However, there was a significant reduction by day 29 compared to baseline. We then investigated the neutrophil activation markers, myeloperoxidase or MPO, and this is released from neutrophil granules in response to activation. And we measured citrin-related histone H3, which is a marker of neutrophil extracellular traps. And we found that MPO was downregulated at day 4 and day 29. However, CYT-H3 had remained elevated from day 8 onwards compared to baseline. To identify if these changes are specific to COVID-19, we then compare these markers and those in the control cohorts. And previously, when we found an upregulation of E-selectin, no upregulation was observed compared to the control groups. And we in fact saw that in COVID-19 at day 1, there was a significant reduction compared to the LRTI group. For VCAM1, we found that from day 1 to day 15, there was a significant upregulation compared to the LRTI group. And when we measured ICAM1, we found that day 15 and day 29, there was a significant upregulation compared to both control groups. When we moved on to von Willebrand factor, we found at day 8 and 15, this was significantly elevated to both control groups again. However, no difference was observed at day 29, suggesting that these values are returning to normal. And finally, when we looked at the neutrophil activation marker, MPO, this was elevated at day 1, 8 and 15, but only compared to the matched controls, and it wasn't higher in the LRTI group. We then wanted to investigate whether these markers are associated with clinical status. And for this analysis, we took the values at day 29, and we split the patients into those with a WHO score of 1 to 2 who had been discharged from hospital, and compared these levels to those who had a WHO score of 3 to 6 who had remained hospitalised by day 29. And we found that for each marker, except for E-selectin, they were all significantly higher in those who had remained hospitalised. We then wanted to investigate whether the markers are associated with ongoing symptoms post-COVID-19 and in those who had been discharged. And for this analysis, we included only patients that had been discharged by day 29, and we split the patients into those with a score of 1 who had some limitations on activities compared to those who had a score of 2 who had some, 1 had no limitation on activities, and those with a score of 2 had some limitations on activities. And we found that ICAM1 was the only marker that showed a significant difference, and this was upregulated in those who had some limitations on activities. We then investigated whether these markers are associated with the occurrence of a major cardiovascular event, and for this we compared those who had MACE up to 1 year post-hospitalisation and compared these levels to those who hadn't. And again, we took the day 1 and day 29 values and compared between MACE and no MACE, and we unfortunately found no significant association between inflammatory markers and MACE. After finding no difference in the level of the serum biomarkers, we then wanted to investigate gene expression levels, and we looked into the peripheral blood transcriptome, and again we compared this between those with and without a MACE, and at day 1 we found no significant differences between any of the genes expressed. However, at day 29, as you can see in the volcano plot, there were 93 significant differentially expressed genes, and the red dots indicate genes that are higher in those with a MACE, and the blue dots are representing genes that are lower in those who experience a MACE. And when we took an individual look at these genes, we found that a subset were related to neutrophil activity. So neutrophil elastase, defensin alpha 3, and S100 calcium binding protein were all upregulated in those who had experienced a MACE. We also found that the coagulation protein tissue factor pathway inhibitor was also upregulated in those who had experienced a MACE. Gene ontology analysis then identified gene sets that were also differentially expressed between these two groups, and genes related to platelet aggregation, type 1 interferon signaling, which is the main antiviral response, as well as neutrophil migration, were all mostly upregulated in those who had experienced a MACE. To summarise, in the serum biomarker levels, we found that some markers related to endothelial and neutrophil activation were elevated in COVID-19, and some of these markers had persisted to day 29, implicating vascular dysfunction in long COVID. And in gene expression data, we found that there was a significant difference between those who had experienced a MACE or not, and genes were related to neutrophil activation, type 1 interferon signaling, and platelet aggregation, suggesting that a relationship between these pathways and increased cardiovascular risk. And I'd just like to thank my team at Dundee and acknowledge HRUK and CSO for funding.
As next steps, which part of that pathway would you target if you were going to treat this and prevent people developing this endothelial dysfunction?
I definitely think targeting neutrophils is important. We're currently doing follow-up of people at like 6 and 12 months post-COVID, and it looks like there's like a more activated like neutrophil phenotype in those people. So I think that, and probably platelets, is the most important steps.
Any other questions? Did you look at the impact of the treatments that we give these patients with COVID, DEX, for example, and what that did to those vascular biomarkers?
We've not done that yet. I think we would need to take into like consideration severities as well, and I think the sample sizes get quite small, although we were hoping that results post-COVID-19 wouldn't have effects from drugs at that point, but it's something we can look into.
Okay, thank you. Sosha.
Hi. So I thought it was nice how you controlled for you had your hospital your COVID versus non-COVID. What I'm trying to work out is if it, looking at what you've done, is if some of those changes that you saw could just have been due to long-term MI effects, as in how much of that effect is due to the MACE itself? Did you control for that? Did you look at those things as well? As in people who'd had a MACE who hadn't had COVID?
No, so we've not got that, but we have got a control cohort that we can look at that as well.
Yeah, because I think that's key to working out what is due to the COVID.
Yeah, I think it's nice as well because we've got longitudinal analysis, so it seems like it is COVID related because we would see changes at day one that would necessarily would do if it was just a comorbidity factor, maybe.